Thank you so much for joining us today. I'm Dr. Claire Abernathy. I teach in political science, and I'm one of the faculty co-chairs of the American Democracy Project / Political Engagement Project, which is the group putting on this event today. Thank you so much for joining us for today's panel about holistic approaches to address the opioid crisis. This is part of our Alternatives to Opioids series. We'll be having another event later this month after Thanksgiving focused on medical marijuana as another potential alternative to opioids, and we encourage you to join us for that as well. I do want to point out just a brief logistical note. Several of you that came in, I already swiped you in for a record of your attendance. If I missed you, then at the end of the event, I'll be out front and can swipe you in so that you have a record for class or for extra credit. So be sure to find me after the event if you need to. So these conversations that we'll be having today and again later this month are increasingly important as opioid use continues to represent a growing public health crisis. The misuse and addiction to opioids, including prescription pain relievers, heroin, and synthetic opioids, including fentanyl, have been increasing over the last 20 years, with a particularly sharp increase evident in the last several years. Opioid overdoses increased 30% from July 2016 to September 2017 across the country, and certain areas have been even harder hit. In the Midwest, opioid overdoses increased 70% over that same 15-month period. Opioid addiction and misuse is responsible for a large number of deaths in the US. Each day, more than 115 people in the US die after opioid overdoses. 2/3 of all drug overdose deaths in 2016 involved an opioid, accounting for more than 42,000 deaths that year, more than any previous year on record. In New Jersey alone in 2016, more than 1,600 deaths statewide were connected to opioid overdose or misuse. Recent projections in New Jersey suggest that opioid-related deaths could reach 3,000 in New Jersey this year. In today's event, we turn our attention to different approaches to reverse course on opioids and address this public health emergency. Our panelists today will focus on options available other than opioids, considering front-end prevention strategies and diversion options to other treatments to help keep people from using opioids in the first place. Our panelists will also discuss replacement options to facilitate recovery from opioid addiction. So it's my pleasure to get us started today by introducing our panel. We'll hear today from Dr. Srilekha Prakash, who's an assistant professor of health science, Dr. Thomas Nolan, who's an associate professor of physical therapy, and Dr. John Gyers, who is an assistant professor of exercise science. First, we'll hear from Dr. Prakash, followed by Dr. Nolan, and then Dr. Gyers. Following the remarks from each panelist, I will moderate a brief discussion, and then we'll open it up to audience Q&A. So I encourage you to think of questions that you have for our panel as we listen to their discussion. So for now, I'd like to turn things over to Dr. Prakash, who will start remarks off for the panel. Thank you.
Rather good evening. Thank you for coming in for this panel discussion, first of all, and I'm Dr. Prakash. I teach in health sciences here. So today, as Claire just mentioned, we'll be talking about alternatives to opioid therapy. That's where I want to start. That's a graph showing you how overdose deaths, as Claire just touched based on, how it is an increasing concern in US. Yes, over a period of time from 1999 to 2017, this is the CDC or the Center for Disease Control data projection, which shows the graph for opioid-related overdose deaths. If you look at this graph, what you see here is that sudden rise, right? That steep rise of opioid use and opioid-related deaths. The blue line, if you can make out at the back, that is synthetic opioid use, not counting some drugs like methadone there. But if you combine those synthetic opioids along with other opioid-related drugs, the latest, what it says is 72,000 deaths in 2017. That's the latest CDC count of opioid-related deaths in United States. Yes, New Jersey also is in this. Again, we are not in the green zone yet. We would like to be. Right now, in last 2017, the latest report says that it was 1,642 deaths last year related to opioids. So why? Why are we here? How did we reach this crisis mode? That's where I want to start. Why did it happen? You have any thoughts regarding that from the audience? I would really like to say, because it took me some time to research and figure out why in United States it is one of the major concerns. Any suggestions, any thoughts related to that? Yep, go ahead. Yes, one of the main reasons is prescription drug use, right? Overprescription of drugs. Why it happened again? In 1990s, as you see, in 1999 to 2017, that's 2 decades, it took us to reach the crisis mode. No, it started in 1990s. There were many factors, including prescription, overuse of prescription drugs, other than the marketing gimmicks with the pharmaceutical companies' introduction of newer drugs into the market, saying that these are potentially better drugs than what you're taking, so why don't use it? Your pain will be relieved. So that thought of, increasing that drug production into the market, familiarity of people or prescribers prescribing it because marketing was so much into it, there was physician ignorance at some point where people did not even know what was the side effect of these drugs because markets were showing so much effectivity of the drug, they got carried on with it. Prescription happened more, yes. Also, there was this thing that pain is bad. You should get rid of pain. Pain is a bad thing to have, so let's just completely get rid of it. That cultural norm, that perspective that pain is bad and get rid of it, that was the theme. So whenever you have pain, so these pain, there are people who are against pain, that kind of a group. So you have those kind of people coming up. So there were many reasons for those kind of influence. Those were like societal influence, and drug overdose became a problem later on because people did not know about it early on, how to start with. We are here right now. So right now we are in a situation where we need to deal with the crisis and how do we go about it. So before we jump into that, I like to show you what pain is. What is a simple way of looking at pain. It's not a very complicated one. You have pain, right? You realize pain or look at pain as 3 things. You have thoughts attached to it, emotion attached to it, and a kind of sensation. Sensation, that is something which is carried by nerve endings or your peripheral nerve endings, which here in this case I'm trying to show you with an arthritic joint pain or a pain which is happening in relation to your hand. It gets transmitted onto your area of the brain through spinal cord, right? That's what a typical simple pain pathway is like. From your joint, it is going on to your brain. But it is not just going on to your brain as in a perceived notion. You have thoughts associated with it, emotions associated with it. When emotions you have emotions playing a part in anything, you get overpowered sometimes. So that was the reason people went for this kind of drug, or why people looked for this kind of drug is because they could control this, is what at least they thought. Sorry. Okay. So how do opioids, that's just an overview, I'm not going into the details of it, but how do opioids typically work is they release chemicals in your brain which give you something called the sense of pleasure. So your thought, your perception of pain is subdued because of that. So opioids are doing that, right? They are trying to work on the brain's internal reward system. They release chemicals which makes you feel kind of, that pleasurable thought or feeling which you have is because of that. Opioids act on them. They also slow down your breathing, your heart rate, because when you have pain, you typically have an increase in your heart rate, You have a higher breathing rate because you have pain. That is, those are some kind of automatic functions which happen in your body. Opioids try to lower them. They also slow or reduce the signals which reach your brain. I said it comes through your spinal cord. So there are multiple areas in your body where these kind of chemicals would work, or these receptors are working. Opioids try to attach to them, and they will prevent those scents to reach your brain. So they have some role there. But people initially, again, when we started, they didn't have any idea that they also could have long-term effects. Like people feel tired and sleepy after taking it, drowsy feeling, right, dizziness. Or there are other complications which I go on mentioning here. In this is there are multiple body systems getting affected with opioids, which people were not aware of initially when it started. But when even after we got that awareness, still people are prescribing it because of the rest of this data which I'm going to show and tell you that it has got abuse potential, which people did not look carefully into. It can affect your blood vessels, it affects your brain, it affects your digestive system. So now, right now, you also see people talking about constipation related to opioid use. Yes, that's a long-term side effect of opioid use, opioid-induced constipation. Your digestive tract slows down, so you have constipation symptoms. Also, on the nervous system, they also have an effect called hyperalgesia. You take opioids to relieve pain, right? That's the thought. After some time, it causes hyperalgesia, or your pain increases with the use of opioids. That's been documented, studied, the research showing that it actually aggravates pain at some point. So what do you do? So that is another problem with opioid, long-term opioid use. Then the heart will be affected because, again, long-term use, it affects on your heart walls. It causes infection in the heart, endocarditis. One of the major issues with opioid is affecting the lungs. How long do you think your brain can survive without oxygen? Any idea how long your brain can survive without oxygen and function normally? So there are different thoughts. People say brain can function more than 10 minutes. No. After 4 minutes, the nerve cells start dying, okay, degeneration. So there will be some kind of problem left with you if you don't have enough oxygen to your brain. And opioid result in it affects the brain, the vasomotor center, and lungs, and cause respiratory difficulty. Most of the people with opioid crisis, if you see, or you will read about it, they die of respiratory difficulty or respiratory arrest, is because of that reason. It affects liver, and it also lowers your immunity in your body. So overall, if you look at it, doesn't seem to be a good thing, right? Even though pain is handled, it is causing so many other problems. Why didn't we look at it? Why didn't we know about it? That is because of so many other problems. There are certain risk factors which we say for prescription drug, right? Which was not carefully discussed or taught by people at during the time or however it started. There are three main factors you look at: psychosocial, drug-related behavior, or genetic factors. You have to look at these three factors when you prescribe opioids. Why? Or not just opioids, any dependency drugs for that matter, because these three factors play a role in causing addiction. That is the problem, right? That is a problem with addiction when these three factors together play a role in a single person. So I looked at research, and I was looking at how treatment plans can be looked upon, right? In a way, it makes sense. Should have a pre-treatment phase and a treatment phase. If we can evaluate people on how they are, their family history, I've mentioned as psychological assessment, as in any previous use of drug or any problems related to drug use, informed consent, right? As in there are risk factors associated with it. These are the problems, or these are the behavioral changes which you're going to have. That has to be discussed. A treatment agreement, because of which, if you have a treatment agreement, the idea is they can actually, they are liable for coming up to you with any kind of misbehavior or any kind of abnormalities happening due to that drug intake. And during treatment phase, we also should be looking at how they are taking it. Is there any change in their behavior? Why don't change into an adjuvant therapy? Don't just continue with opioid for so long. Rather, even if you start it as an acute treatment or an initial phase treatment, change it to something which is not so addictive, right? That is another way of looking at it. So the alternates which we look upon here are other drugs. Why opioids? Why can't we start on treatment drugs without addiction like steroids, NSAIDs, typically called as NSAIDs, but non-steroidal anti-inflammatory drugs like ibuprofen, acetaminophen. There are drugs which can actually reduce this. They don't have addiction properties. Physical therapy, exercise, my colleagues are going to discuss about that. Chiropractic treatment. Chronic pain is mostly due to, it is also seen that chronic pain is induced by your posture, difficulty or different kind of postures which are inducing it. So probably people should be educated about postures or ergonomics. Acupuncture, still under research, but yes, it is seen to be effective for chronic pain like osteoarthritis or chronic back pain. They have shown effectivity. Or yoga. Studies have shown that yoga helps in how you perceive pain. And there are studies which prove that. Meditation and cognitive behavioral therapy, where you actually sit with somebody, talk therapy. Now it is happening, like the alternative therapies, they are looking at something called, you're identifying your pain, talk about it, and find out a plan which works for you. In a way, how you're going to conceive pain. That's the idea. You conceive pain in a different mode. This is a research, ongoing research in Stockton, which we are doing. Surveyed around 1,200 students. Some of you might have taken that survey. Most of them were females. Again, between 18 to 20 years. It's a general report I'm showing here. But if you look at it, most like 22% of those who said who are on medication, of which 5% were on pain medications. And that, again, it was an initial survey result. I'm not saying it is the total survey, but yes. And more than 90% actually thought painkillers are bad, but still, out of which you say 5 to 6% were on painkillers. And Percocet was one of the drugs which, percentage-wise, I haven't come up with the percent here, but Percocet ranked as the top drug taken by students in Stockton for the last year. In the last year, if I checked, that is one of the drugs. Why I didn't check that? It was a survey just to see what is the drug use, misuse habits in youngsters. That was the thought survey I was looking at. So it said that it shows that there is some kind of a problem within the youth too. So why is that? Why are we here? I said the crisis is happened because of so many factors. How can we change it? Is with these kind of alternatives. So what are alternatives? As I discussed, other than this, the drugs, there is research happening all around the world. They're looking at how to wean off. There are people who are already in the opioid bracket, in the abuse side, on the abuse side, and there are people who are still getting prescription right now. While we are talking, there are still prescriptions happening in United States. Why are we not using it then? What can we do about it? What do we need to do? It is the perception. First and foremost, we need to have change is that why should you not have pain? Is pain actually a bad thing to have? Why should you even think about taking a pill in the first chance where you have a pain? Why do you think of taking a pill, right? That is the idea. We will be discussing about it a bit more later on. So I will stop here and will invite Dr. Nolan to continue with the physical therapy attitude of it.
Good afternoon, everyone. I'm Thomas Nolan, and I've been a physical therapist for 40 years now. 30 of those 40 years I've been here at Stockton teaching in the physical therapy program. The problem I want to talk to you about today is the prescription of opioid analgesics for musculoskeletal pain. You've heard of these drugs, I'm sure. OxyContin, Darvon, Vicodin, to name a few. They've been prescribed for musculoskeletal pain such as back pain, postoperative pain, chronic pain. And we know that one of the results of that, as you can see in the slide, prescription opioid deaths have quadrupled since 1999. Common misconception is that opioid analgesics are safe and effective for pain. But the reality is they are dangerous drugs that should only be used for severe pain, such as cancer pain. Side effects of opioid analgesics can be minor, such as nausea, vomiting, constipation, but they can also be severe, such as depression, addiction, tolerance, physical dependence, and death. There are safer and effective alternatives for the management of pain, and that includes physical therapy. The American Physical Therapy Association has initiated a public awareness program to combat the opioid crisis and promote physical therapy as a safe and effective alternative to opioids. And you can see it listed here, #ChoosePT. You can get more information at moveforwardpt.com about this campaign. Physicians often prescribe opioid analgesics for people with back pain. However, studies have shown that these drugs are largely ineffective for the management of back pain, especially compared to other interventions such as physical therapy. A published study in Health Sciences Research found that people with low back pain who saw a physical therapist first, before a physician, had decreased use of opioids by 87%. Norton Hadler, who's a rheumatologist, is the author of a book, Stabbed in the Back, Confronting Back Pain in an Overtreated Society, states that none of the many treatment guidelines for low back pain include the use of opioid analgesics. Yet opioids are commonly prescribed for people with low back pain and associated with poorer outcomes in this population. The earlier the opioids are prescribed, the more likely that a patient will not improve. The good news is that there are effective, safe alternatives to the use of opioid analgesics for the management of pain. And physical therapy is one of them. In fact, the Center for Disease Control, the CDC, recommends physical therapy as a preferred alternative to opioids for the treatment of pain. It's off a little bit, I don't know why. Physical therapy focuses on the movement system. And that's how we move our bodies for all activities of daily living. And by analyzing movement patterns, physical therapists can diagnose movement dysfunctions and design corrective measures to restore normal movement. And these interventions can often be effective in managing pain. It's by faulty movement patterns often are involved in the production of musculoskeletal pain. So to prescribe an opioid analgesic is just masking the pain. It's not doing anything to correct the problem. Interventions by physical therapists can include exercise, and exercise has been shown to have people who exercise regularly it's been shown that these people have less pain. Electrotherapy. This is a TENS unit you can see the patient using in this slide. This TENS unit provides a weak current via electrodes applied to the skin, and the nerve endings pick up this tingling sensation from the current, and it's transmitted to the spinal cord. And in the spinal cord, the message of pain can be blocked. So people can then go about their activities of daily living, they can take care of their children, go to work, by using one of these devices. And it may help to eliminate the use of opioid analgesics for pain, or perhaps even cut down on the use of those opioid analgesics. We've found lately that education is very important regarding the use of opioids and also the cause of pain. Many people don't understand that pain is a normal phenomenon. Very few of us are going to get through a given day without experiencing some pain. So by explaining the neurophysiology of pain to patients and helping them understand that pain occurs in our brain and may or may not be connected to an actual physical dysfunction or a physical problem, often helps people to be able to cope with that pain. Pain serves a purpose. It usually tells us that something is going wrong in our body. So to mask it by using any type of medication, particularly an opioid analgesic, is just masking the problem. It's not effective, and the opioids cause major side effects. So studies have shown that physical therapy can be an effective alternative for the management of pain. When in pain, receiving physical therapy first as a first-line intervention will often help to decrease the prescription and abuse of opioid analgesics. So the question is, why do people regularly go to a physician and have an opioid prescribed rather than go to a physical therapist? And why are physicians not regularly referring people to physical therapy if it's been shown to be effective in helping to control pain? Well, there's some possibilities here. I think one of them is that modern society seems to want a quick fix for complex problems such as pain. And just prescribing a medication such as an opioid analgesic and taking that medication seems like a quick fix, and it's often not effective. We all know that the pharmaceutical companies have promoted opioids as an effective and safe intervention for pain, and we now know that that was a lie. They basically lied to us, they lied to the physicians, and they promoted these medications as safe. And look at the mess we're in now. You may have seen, I know I saw in the news today that the state of New Jersey is suing Johnson & Johnson because of the promotion of opioids for the use of patients for treatment of pain. Some physicians lack the knowledge about the dangers of opioids and also lack knowledge on the effectiveness of physical therapy. And also the general public also has misconceptions about what physical therapy is. The use of physical therapy requires usually repeated visits. It's not a quick fix necessarily, but studies have shown that it can be effective. Insurance companies often limit the number of physical therapy visits. They have a misconception that physical therapy isn't effective. However, if they give it time, if they allow patients to go for the prescribed physical therapy appointments, and they provide the coverage for that, I think they'd find that in the end it's better than prescribing opioid analgesics. And also, many patients have coverage, but they have high copays. So if you have a copay, meaning you have to pay $50, even though you have coverage, you have to pay $50 for every physical therapy visit. Many patients can't afford that. Most physical therapy sessions require you to come several times a week, maybe for several weeks. So the cost can get up there, and people sometimes can't afford that. And then we also have the lack of understanding of what causes pain and how to treat it. So I think all these factors taken together helps to explain why physical therapy hasn't been utilized as much as it should to help combat this opioid abuse problem. What is needed is a multidisciplinary approach to treatment of pain. It's not just physical therapy, it's not just the medical intervention. It also many times requires psychological intervention, also requires social workers, occupational therapists, everyone working together, vocational counselors, to try to figure out why is this person continuing to allow pain to stop them from doing what they want to do in their lives. Why are they not able to work? Why are they not able to take care of their family? And why is it stopping them from enjoying their life? So it takes a multidisciplinary approach, and our goal is to have a multidisciplinary approach, an affordable approach to pain, to treatment of pain, not using opioids. Thank you.
How you doing? I'm Dr. John Gears. I'm an assistant professor of exercise science. I walk around a lot when I talk. It just helps me think, so I'll be back and forth throughout the stage. You know, the hardest part, let me switch over to my official slides first, wrong way. All right, so the hardest part about a talk like this is trying to figure out where to start. So I'll start here. Every year I go to a few scientific meetings throughout the country, and people always want to know about you, want to know about your research, and you know, I tell them I'm an exercise physiologist. And then I say I study the effects of exercise, has on different physiological systems, and how it can be beneficial for treatments of chronic diseases and things like that. Half the people are interested, and half the people give me a really funny look because you're saying, you use exercise to treat disease? Who does that? Because it's not a pill. So, you know, I came to this conclusion when I was a doctoral student. Take a disease like cardiovascular disease. We know that cardiovascular disease is largely preventable with exercise and proper nutrition. But yet we spend billions of dollars on trying to develop new drugs to prevent cardiovascular disease. When, if we watched our weight, we watched our stress levels, and we exercised, we wouldn't need to take any medication at all. So therefore, is it perhaps a need for more drugs or perhaps of a complete behavioral swap in the country that we need? So I think our thinking is a little backwards there, because I'm going to tell you something. Exercise is the most powerful treatment in my mind that you can possibly have. So we can treat diabetes, type 2. We can treat cardiovascular disease. We can treat cancer. We can live longer. We can live better. We can treat depression. We can treat anxiety. We can treat stress. And today I'm going to tell you, you can treat addiction as well. Again, a lot of you probably thinking I'm kind of full of it because it's not a pill. It's not something else we put into our body, but I have a few minutes to convince you otherwise. So moving on. Now, Nora Volkow, Dr. Nora Volkow, I'm kind of a nerd, so I actually do have like a 5 top favorite scientists, and that's one of the nerdiest things you could possibly say. And she's one of them, all right? So she studies addiction. And it's kind of hard to see. This paper was published in New England Journal of Medicine, and it was entitled something along the lines of Science's Obligation to Treat Drug Addiction, or the Opioid Epidemic. And let me see, can I figure out which one is the pointer on here? The middle. Okay. So what you see here is a whole slew of different remedies. And every single one of these is something like brain stimulation. We have stronger drugs. We have drugs that work on opioid receptors but just aren't opioids. So it's basically a different type of opioid, essentially. We have current opioids, but they just have a little twist to them, so they make them a little bit less addictive. So we have all of these different approaches to treating addiction. Not one mentioned in this review paper exercise or anything like that. When there's actually data and there's studies out there to back up that it's actually a pretty good solution to the problem. So today I'm going to talk a little bit about how exercise and drugs work on the same exact receptors in your brain. So there's opioid receptors in your brain. Exercise activates them in the same fashion. And I'm going to show you a few of my great graphic art pictures of some mice representing a study where they've actually found that animals actually prefer exercise when they're addicted to drugs. So you can get a mouse addicted to cocaine. You introduce exercise and it stops doing cocaine. So a lot of what we know about drug addiction actually comes from exercise addiction. So I don't know how many of you know you can become readily addicted to exercise. And the side effects are the same as being addicted to drugs. So if you look up here, just some of the symptomology. So it leads to dysfunction in everyday life. People become so addicted to exercise that when they don't get that stimulus, they shut down for the day and they don't do anything. They feel sick, they're miserable, they feel hurt, they crave it. So does that sound familiar? Does it sound like someone's addicted to something? It's the same thing. So we can actually look at these people who are addicted to exercise and compare them to people who are addicted to drugs. And what you'll see is it's basically the same pathways that are active. And tolerance increases, all right, in terms of runner's high. So has anybody ever out there heard of the runner's high before? Has anybody ever think they experienced runner's high? It's not as easy as you think, because you actually have to exercise pretty hard. Most studies have shown exercise intensity has to be pretty high. But essentially, what exercise does at the proper intensity, it creates a state of euphoria, it creates a pain-killing effect, an antidepressant effect, all in a very acute term. So after a bout of exercise, if you worked out hard, you should probably feel pretty good. That's usually like in the morning, I go to the gym, and I feel good for about 20 minutes before the stress of the day hits, right? That's usually what happens. So it's a very real phenomenon, this runner's high. And studies have shown it works, the runner's high works the same way as marijuana. It works on a lot of those same receptors in your brain. So essentially, it's really exercise-induced high. And there's many theories why this occurs. So there's a pretty potent pain-killing effect, as I mentioned, with exercise. An interesting theory about this is that it's more of a ancestral trait. So recognize right now, humans are predators, not prey, but at one point we were prey. So if you're running away from something that was trying to get you, the pain-killing effect actually allowed you to run through pain. Okay, so that's a theory on why we get that kind of analgesia, as they call it. So pain-numbing effect in acute term. So this is just a study. It's a lot of bars up there, but I'll get to the main point, what I want to show you. So this is post-exercise. So this BAMS rating is just a rating, it's a scale of how you feel after something, how you in terms of happiness, fear, whatever. So if you look here, happiness at rest versus happiness following a run. People report they feel happier after a run. So on a day like today, well, don't run outside because it's absolutely miserable outside. So it's cold. Depending on if some of you are going home someplace else, it might be sleeting or snowing, which is horrible. It's cold, it's raining. You're getting towards the end of the semester, even though Thanksgiving has come up. You might be getting stressed out about exams. Everybody has to deal with stress in a different way. Some people turn to cigarette smoking. Some people drink alcohol. Some people gamble. Some people listen to music. Some people punch things. But it all essentially does the same thing. All right, so it releases dopamine into your brain and kind of gives you a little bit of an escape. It gives you a short-term release of dopamine, which causes euphoria. Exercise is the same thing. So if you're looking for a way to get rid of stress, go for a little bit of a run or go to the gym. Okay, so it's a healthier alternative. So here we see happiness. We see, what else is important here? Fear. A little bit less fearful when you go for a run. So if you have something coming up that you're a little nervous about, exercise before. Exercise before an exam. Where you get euphoria is the big one. That's a big jump in euphoria. Okay, again, that's just a feeling of runner's high. So exercise is this powerful tool at making us feel better. So if you think about it, a lot of people turn to drugs, turn to opioids because of stress, anxiety, things of that nature. If you can remove that from your life by a healthier alternative, then perhaps it never becomes an issue to begin with. A lot of people who use opioids are actually very high achieving. Graduate students, medical students, people you wouldn't suspect. And that's all about the stigma of opioid abuse. The reason this population uses opioids so readily is because of anxiety and stress. Nothing to do with pain. They want to feel better because they're stressed out. So again, replacing this not potentially, dangerous habit with something that we know is safe and is actually good for you in the long run, is a worthwhile thought, at least, in my professional opinion as an exercise physiologist. So I come up with these great pictures in PowerPoint, so I at least throw them up there once in a while. So in the 1950s, this approach was pioneered by Olds and Milner. So essentially what they did was they hardwired mice's brains. And, they had a lever, and they realized in certain parts, when those wires were connected to certain parts of the brain, the mice would touch it, and they want to touch it again, and they want to touch it again. They later found out that hitting that part of the brain was releasing dopamine and causing a pleasure and reward response. So now we use this approach a lot to study different kind of drugs. So when a pharmaceutical company comes up with a new drug, this is a common way to test. The more time the mouse hits the lever, the more addictive it is. Okay, because that mouse knows, it learns that every time it touches that lever, it's going to get drugs delivered. Now, this has been reported in a lot of studies. See how I had the running wheel over there? That's That's scale. That's what happens when you go get a PhD. You learn how to do things like that. We learned, and again, one of my top 5 favorite scientists, Nora Volkow. Maybe she'll see, this is being recorded. Maybe she'll see this one day and send me an autograph. Be cool. Hi, Dr. Volkow. Her lab, she works for the NIH. Her lab actually had a great study. Was it in, I want to say 2006, I'm not 100% sure. Had a study where they got, they were rats addicted to cocaine, and then they gave them a wheel. Once they gave them the wheel, the rats stopped using cocaine. They found that running was more pleasurable. So is it such an abstract concept then, we can translate some of this into humans to treat addiction? Now, I'm not saying it's always going to be a standalone therapy for drug addiction because it's such a difficult problem to solve, but at least an adjunct therapy? Can you at least put a gym in rehabilitation centers to give them the, people addicted the option of having some kind of healthy outlet, healthy stimulus to use, okay? Because we use rats for reasons because, believe it or not, they're pretty similar to humans in a lot of ways. I mean, they're small, furry. Rats are cute. I mean, I don't know if not sewer rats, like New York City sewer rats, but regular rats are kind of cute, and they're really smart, too. Not that bad. All right, so how do we know this is mediated through opioid receptors, dopamine release? Well, we can use a drug called naltrexone. Now, naltrexone, if you're not aware of, is used to treat addiction. Alcohol addiction has been shown to be somewhat effective for nicotine. They actually throw it in weight loss pills because eating stimulates dopamine. It's rewarding. So, again, some people, when they're down, what do they eat? They go, high-fat meal, and they go to, McDonald's drive-thru, or they go look for a piece of cake, ice cream, because it releases dopamine. So now naltrexone is thrown in there, too. It's kind of a fix-all for this type of situation. But we can use it in different types of studies to show that the dopamine pathway is responsible for some of these rewarding type behaviors in exercise. So this study was really interesting. So you give a rat or a mouse a running wheel, and they love to run. Spend all day in there. It's like their favorite thing. When you start to give naltrexone, which blocks those opioid receptors, you take away that dopamine response, they stop running. So this tells us, why do they run to begin with? Because it's rewarding. Because it's acting on the dopamine system. Same thing that something like an opioid does. So these two systems are parallel with exercise and opioids. So if you think about it, maybe this whole concept of using exercise as a treatment, or at least a pre-treatment in a way to prevent people from using drugs to begin with, isn't such an abstract, crazy thought. Because there's a lot of sciences backing this up. All right, so this is a little bit of a crazy figure. But the point of this is another reason exercise is powerful at preventing opioid abuse to begin with. It's great at managing chronic pain. And there's several reasons. So what this is change of VO2 peak. So I know there's some exercise science students out there, so hopefully they know what this is. But I'll explain it to everybody else, right? So VO2 max, VO2 peak is aerobic capacity. So essentially it's how long you can exercise for. It's a way we can quantify getting in better shape. So this is, on the y-axis up here, is just a measure of pain tolerance. What we find is when we train people and get them in better shape, their pain tolerance goes up. There's several different reasons for this. There's hormonal changes. Okay, some hormones go up, some go down, which control pain sensitivity. There's psychological changes, so just perceived pain changes. So exercise can be kind of painful itself, so you learn to deal with that pain. So that's another response. All right, so the last slide I want to show you is, this is some of my data, actually. Right now my research interest is exercise paralleling fentanyl abuse. So what this is, it's a PET image. So what we do is we deliver a radioactive marker, which is FDG. So it's a marker of glucose uptake. If you know about the brain uses glucose for fuel. So we can actually look at brain activity by seeing how much glucose is being taken up by the brain using this marker. So what you see here is this is a mouse's brain under control settings. So if we just scan a mouse brain, this is the baseline level of activity. This is the activity following exercise. Brain activity goes through the roof. So that suggests that there's a powerful stimulus following exercise. So really what I want to do is follow up on this, look at specific pathways, and also, oh yeah, one more thing is, I don't have the slide here, this goes away when you use naltrexone. So that increase in brain activity is due to an increase in dopamine release. Okay, so what I want to follow up is we're going to give fentanyl and kind of compare and contrast mechanisms there. Well, thank you for your time, and looking forward to the question session.
Dr. Prakash, you noted at the start of the panel that many people are first introduced to opioids through prescription drugs, right? They're prescribed these opioids. So are there policy changes that you can envision that would lead to a decrease in the actual prescription of opioids, a policy we could pursue to reduce the prescription to begin with?
Yes, so actually there are a few regulations. Something called the prescription monitoring system, which is already in place, where you are supposed to report, like within New Jersey, you will see like how many people are actually prescribing opioids for their patients and for how long are they prescribing. So that was one thing which, again, is a problem as policy change which we'd need is, how do you control those people who go change doctors? So today, if I'm prescribing opioids, my patients, maybe there are people who are happy because I'm prescribing, the pain is gone, they'll come to me again. But the day I say that, it's done, you cannot get more opioids now, your time is over, there's a policy which is, from the people's side, what you have seen is they just shop for somebody else, right? They go for, that is called, they go change their doctors, or they go to another doctor, they get prescription done. That is one thing which has to be controlled. Like there has to be a central monitoring, even though it is there in place, more regularity. I mean, it has to be regulated better. In a way, you can control that, shopping for pills. That's something policy-wise can change. Another thing is insurance companies, as we said that, there is a limit to alternative therapy because of insurance policies like people have. Prescriptions are covered, alternate therapies are not. So that's a big problem. That's one of the main problems where you can tell a person to take prescription because it's covered under their insurance. You cannot tell a person to go do exercise or do physiotherapy because they will only be partly covered. That's another problem from the insurance perspective. So there are policy changes are needed for controlling it. From the prescription perspective, yes, acute should be taken care of, but for chronic pain, definitely we should look for alternatives, and that has to be ingrained into people's minds.
So you all have outlined several different alternatives or other interventions, and Dr. Nolan, you spoke to this a bit, but any of you can feel free to build on it. Could we reflect again on some of the reasons why these alternatives have pretty systematically not been pursued or been sort of the secondary option, and the sort of default has been to prescribe a prescription or an opioid in particular? So what are some of the reasons these alternatives haven't been actually an option presented to patients?
Well, I think one of the reasons is just lack of knowledge, the understanding that there are alternatives to opioids. It was pushed back in the 1990s, I believe it was, when this program or this thinking started that nobody should be in pain.
Yeah.
What a preposterous thing, but nobody should experience pain. So pain became the fifth vital sign, and everybody should be medicated for pain. Nobody should feel any pain. If you're in the hospital and the nurse comes in and says, "Are you feeling any pain?" and the patient says yes, oh, we've got to put you on an opioid. You've got to have your drugs to take you out of your misery. Well, it takes a different thinking, a different thought process, that pain is part of the life experience. Now, yes, of course, sometimes pain gets out of control, and then it's difficult to get it back into control. But if we start from a premise that there's a reason the person's having pain, and instead of prescribing the drug, prescribing the opioid, and go away, now you've got your opioid, you'll be okay, all you have to do is take this opioid analgesic and you'll be fine, that's faulty thinking, and it fails to recognize, as you were saying, exercise. Exercise stimulates the same opioid receptors in the brain. So you usually, it's rare to die from exercising. I know it happens. But it's much safer.
You may feel like you're going to die sometimes.
You certainly do, right? Especially if you're running a marathon, maybe. So I think that's part of the problem, is that we have to, it's a paradigm shift where we have to get away from this idea that you have pain, you shouldn't experience pain, therefore you need a drug to take away your pain, and then you'll be happy. Well, we need to shift away from that thinking. If you have pain, first of all, let's sit down a minute. Let's take a little time with our patients, physicians, therapists, chiropractors, whatever. Take some time with your patient and let's find out what's going on in their life. What could be causing this persistent feeling, this perception? Pain is a perception. It's in your brain. What is causing this persistent perception of this feeling that is intolerable, and this painful feeling that's intolerable? And can we get to the bottom of it, and what approaches can be helpful, and not just the quick fix, not just the opioid analgesic prescription, and go on your way?
Can I build off this just a little bit? So one of the reasons exercise is hardly ever recommended, it's really hard to prove it. If people don't like to exercise. So if you try to set up a really nice study using enough people to prove a concept, and you make them exercise for a period of time, they usually quit before the end of the study. So what you'll see is a lot of papers that make assumptions are based on what people consider too low of an N, too low of a number, too low of a subject pool, and also in humans who exercise, there's a lot of variability in terms of you're not controlling everything they do. So you give them an exercise stimulus, but they can be also doing a lot of other things outside. And there's also medications and all kind of other confounding variables. So when you're considering a treatment plan, and again, this is, you think about clinical trials and the way they run that in the country, exercise usually won't fit the bill because it's not done strictly enough. So when it comes to recommending exercise, usually you'll see in the review paper, the study, all the studies that have shown exercise, aren't conclusive enough for this, or they're not powerful enough for this. So that's one reason exercise kind of falls by the wayside in terms of recommendations for a lot of things.
So I'd like to focus a little bit actually on this idea of pain education that a couple of you have brought up, and what that would look like, and what we know about how effective a sort of better understanding about the neurology of pain could actually be in helping us identify the source of it and manage it even without turning to an opioid. So how would pain education work, and how effective do we think it would be?
Well, I can comment on that. In physical therapy, we call it explain pain. And first of all, we usually have maybe some posters or maybe some handouts, and we show the patient neurophysiologically what's going on, that there's something within your body that's causing this signal to go up to your brain, and your brain is interpreting it as something undesirable. I mean, we have signals going to our brain every second of our life. Some of them are pleasurable, most of them are neutral, and some of them are undesirable. So all those signals going to the brain, if you're in pain, you're experiencing one or more of those signals as being undesirable, as being intolerable. So we start with that, and we also explain that it's very important that you do experience pain, because that's the body's way of telling you that something is wrong. Something needs your attention. So pain, it's flipping the concept from pain is bad to the idea that actually pain is good. And that sounds really crazy to say that, and especially to say it to somebody that's in pain, especially chronic pain. But we have to shift the whole thinking that, that pain is not something that has to cause you to shut down your life. you can function. And I'll have a person maybe say to me, well, but I can't function. That's the problem. I have this pain and I can't do anything. I can't work. I can't exercise. I can't enjoy life. Okay, well, let's start with what you can do. You obviously got here today to physical therapy. You're standing in front of me. So how did you get here? Well, I drove here. Well, how were you driving? Well, okay. Okay, well, if you're okay driving there, okay, so you're okay there. When are you not okay? So we tie those sensations that they're experiencing in the brain to something more concrete. And from there, we can work with the person and say, okay, these are the things you're able to do. These are the things you're not able to do. Let's work with that and see maybe what things are you not able to do that you'd like to be able to do. And we don't use pain. One of the mistakes that I know we've made in physical therapy for many years in the past was, if it hurts, don't do it. So we'd get an exercise program to a patient. Okay, we need you to do 20 reps of this exercise 3 times a day. And we say, but don't do it if it hurts. And the patient's looking at us and say, but I have pain right now,
Why should you even start?
Yeah, of course I'm not going to do these exercises. It hurts. Okay? So we don't do that anymore. We say, this is your goal. 20 repetitions of this particular exercise 3 times a day. Keep a log. How many times did you do it? So you come back for your next session of therapy. Okay, how many repetitions did you do? Oh, I was only able to do 10. That's fine. You did 10. Your next goal is 20. Oh, but I had pain. Well, I understand you have pain. We understand that. But you did 10. Your next goal is 20. So rather than being focused on the fear that they have pain, they can't do anything, we focus on what can you do, and we set goals, and we work toward those goals, and we don't let pain get in the way. And I'm not going to kid you. I'm not saying this is easy. I'm not saying this is this is something the patient has to buy into. But as far as the whole education process is, we teach the patient that there is something you can do, and we can help you overcome what pain is not allowing you to do.
To piggyback on that, so I work with drug court, also again with drug addiction. So people who are already there, we have seen response. Why I say that is because brain, as we said, brain is something which perceives your notion of pain. So use that brain to handle pain in a reverse order. So it is seen that with kind of alternate therapy like meditation, which I actually saw the positive results. With meditation, what I saw was, actually, have you seen people who get injured on court? They go out and after 10 minutes, they just come back and they play again. Do you think the pain just disappeared? Or something happened? Or is it always by drugs? Not necessarily. It is, yeah. So that is actually that kind of, that high, as you call it, it happens. So, and they tried it with meditation and saw there was positive result. So you are masking pain anyway with drugs. Can you do it otherwise? I'm not saying you can not use drugs at all. Again, there are cases, again, for chronic pain. Because of all these talks, I was reading about in an article where they were discussing, because of you people, we are not getting good drugs. Like the cancer patients or chronic people who think that they need it. We are not getting enough drugs. What do you do? What are you trying to preach here? Is another school of thought. So there what we say is, why not try something alternative, alternative therapy to your patients rather than giving them directly opioids. Try to wean them off, try to do something like a adjuvant therapy. With drugs too, you can do it. You don't have to do directly opioid and continue with opioid for months. I know people who are on opioids for more than 6 months. Research has not approved yet that opioid has effect on chronic pain. That's not proven yet.
That's right.
So you cannot even say that opioid prevents chronic pain. So opioid treats acute pain. That is there. But after that acute phase, you have to move into some adjuvant therapy. So when we say pain education, that is also to educate them that you're not going to get this drug for your life. That's not the thing. You are not going to get it for the next 6 months. That's not how it's going to work. If you start off with that kind of a plan or educating people about it is not the drug which you need for your rest of your life, rather tell them that it is going to only help you with the initial phase, and now we move on to these therapies sometimes. For others, yes, as Dr. Nolan said, you can start off with physical therapy, not necessarily always on medication. That's also an alternative.
So Dr. Gears, you talked about the neurological pathways for opioids mirroring some of the pathways that are sort of activated in the brain during and after exercise. I'm wondering if you could speak to some of the ways we currently wean people off of opioids, some of the other alternative therapies like naloxone and things like that that are used. How does that sort of activate or interact with those same neurological pathways?
So the main way right now that we treat opioid addiction is by just using drugs that essentially block those receptors. I mean, and that's it's an effective way to go for a period of time. But the problem is, it's expensive to maintain for one, and the relapse rates are still very, very high, because you essentially would have to have somebody on those types of drugs all the time. And the problem is, what happens when if you're blocking those pleasure responses, there's pleasure receptors and that pleasure response, you're going to get people getting very depressed, okay? Because it's not just blocking it for opioids. You're blocking those receptors, which are again, dopamine is what causes pleasure in the body. But if you just try to block that altogether, I mean, you're going to decrease pleasure. And actually, with those graphs that showed up there, one thing we've seen with these mice as well is, under baseline conditions, if you just give naltrexone, which is used to treat addiction, brain activity goes down even farther from baseline. So that speaks to something as well. I mean, whether we haven't quantified what that means quite yet, but it's definitely affecting the brain in another way. So really all you're trying to do is replace one drug with another drug. Or sometimes what happens is you replace one highly addictive drug with a lesser addictive drug and try to wean people off that way as well. So again, I mean, the problem is it's really hard to treat the underlying symptoms of addiction, because essentially what it does is it changes your brain. It changes your brain and it acts completely differently. You just learn to become addicted to something, and you can't really shift it back. So coming up with other strategies to deliver that pleasure response by not just blocking it altogether, is kind of, why I'm interested in exercise, because you can still get a pleasurable response from exercise without using a dangerous substance.
So I have one more question for our panel that I'd like to ask. So if other people in the audience have questions, we have mics up front here, so you can come on down to either side and ask our panelists some questions. So I want to sort of leave my questions with us looking at policy interventions that we could actually pursue to promote these alternatives. What changes should we make in policy to make it more attractive to pursue physical therapy, or to let people know that it's an option, or to promote pain education? What are some policy changes that we could actually make in the state or at the national level to make these alternatives more accessible to people?
Okay, so I will just start at least by saying, as I earlier mentioned, one of them is to let, again, this coming from the clinical side and seeing things happening, one of the main things I could consider is change in insurance plan. That is one of the main things I would think as comes first to me, is include these as a covered thing. Like, when you say you have to do, like Dr. Nolan was suggesting before, I know there were patients who were told 10 visits. They were only covered 10 visits. For chronic pain, 10 visits might not help. You might need more. You will do 10 visits, they reassess, and they might tell you to come for 10 more. That won't be covered by insurance. So you're stopping midway, or partly only getting treated. So what they do is they get partly treated and then go back to drug again. The relapse, or people going back into opioids, that rate is much more than people getting into opioids. More than 90% is the relapse rate for opioid as it is seen. So it is very difficult. So for people to continue with alternate therapy, we need policy interventions like that, where you can advise them to go because they will be covered. That is some kind of a policy change which we need and which is not happening right now. Also, the drug companies, as we say that US is #1 in research. Pharmaceutical research is maximum happening in the United States, right? Painkillers. People take painkillers. 30% of US population take some kind of painkillers. These are all statistics coming out. Should not be proud of those statistics. It is not a good thing to have so many pharmaceutical companies making the drug and US using it. So I was discussing with my colleagues before that, if you look at prescription painkillers, more than half of prescription painkillers is consumed by US population. It's not, again, a good thing to be done. So where is it happening? How is it coming to United States? Why do we have these people not getting addicted to these things when doctors are not prescribing? They're getting drugs outside too. So there are drugs flowing into the country. So that is some policy change which needs to be, again, taken where how can you prevent synthetic opioids coming into the market right now? Fentanyl is one of the major killers of drug overdose, and it comes cheaper than opioids. Doctors don't have to prescribe it. They still get it. So how can you control those? As one or two things which I can think of is how can you prevent getting these drugs or availability of drugs as accessibility and availability. How can you control that? And also include insurance into it as one of the modalities. Anything else?
And I certainly agree as far as the changing the insurance company policies. I could go on and on about the ills of our current healthcare system and the need, I think, for a whole new system to be in place that would allow for alternatives, which are not currently being allowed for now because of the insurance company policies. And I think another important part of this is education. Education is so very important, and I think that's one great reason to have this panel discussion. Thank you, Dr. Abernathy. This is really a great idea. So that everyone is educated on the facts, and we need more money to educate students in grammar school, high school, college level, and the general public that drugs such as opioid analgesics are dangerous and that there are alternatives. And what are the reasons also, as a society, what are the reasons why our American society seems to be craving these drugs? What are the ills in our society that seem to be driving this opioid crisis? There's so many things I could think of, but we need to put some pressure on our elected representatives to listen and to do something about this crisis. I know that on the federal level there was legislation passed. It went to the president's desk. I'm not sure if he signed it or not, but it was back in the beginning of October. Was it signed by the president? The opioid bill that was passed by Congress. Last I saw it was going to the president, so hopefully he signed it, and it would allow for things such as education and alternatives to opioids.
And I'll just one last thing on that. I think part of the issue as well is, part of the solution I should say, is just encouraging extracurricular activities at the youth level, and just as a society actually going outside again and playing and doing things. So even if you look at the influence social media has, people who spend more time on Facebook tend to be more depressed. People who are depressed tend to use opioids, and we know that drug overdoses are going up, opioid overdoses, suicides are all going up, yearly. So, I'm not blaming social media, but I am, blaming the fact that people aren't going outside and playing and doing things, and, particularly young children. So, growing up in a situation where you're not having those experiences, you're not having that physical activity, those interpersonal connections, where people tend to shut down, where they rather stare at their phone and talk to each other. That's not good, and then you don't have coping skills. So when you don't have coping skills and learn how to talk to other people, you have to go and find something else, which, tends to be something like an opioid. So I think just changing the nature of our country to once again be more active and outgoing would go a long way.
I have a quick story to add to that. We were talking about social media, and I work with a Boy Scout troop and I was just talking to the leaders of this troop that just went on this camping trip a couple of weeks ago. And so I asked them, how did it go? You know, they're outside, they're in the woods, you know, out of the city and all that. And they said, well, we had a problem. So what was the problem? We couldn't keep the scouts away from their cell phones. I said, what do you mean? I said, well, you know, they built a fire, you know, like a campfire, right? So they build the fire, and then they turn around, the leaders would look and say, there they were back on their phones again. It's like, all right, well, then we're going to go for a hike. And then they're going for a hike, but they're on their cell phones again. It's like they had to constantly say, will you put the phone away? You know, enjoy the outside. You don't need to have that phone in front of you every second of your life. And it's a problem.
That's an addiction itself, right?
What's that?
That's becoming an addiction itself.
It is an addiction. Yeah. I think you're right.
Well,
there's some evidence
it's
of
been,
that.
No, it's been shown that there's dopamine
shown.
responses to getting text messages, so it's addictive.
Wow.
I mean, if you build a fire, you have to put it on Instagram.
Yeah.
You can't build a fire and not get at least 50 likes.
There you go. That's what it was. I was like, hey, look, we got a cool fire here.
No, but there's actually recent evidence showing that getting text messages and getting likes on social media creates a dopamine response.
Right.
Hence, we're going through the cycle of it's
Getting
addictive.
more likes.
Yeah.
Oh.
So it's a neurobiological behavior, right? So it's how we are training it. Again, as we said initially, as John also pointed out, it's the same. It's a neurobiological behavior which you have to encourage. And as I was taking the survey, I'm looking at the survey, I see there's a demand in the youth population for educating them about the drug behavior. Nobody teaches, I mean, they teach them math, science, everything in high school level, because they say that you're not there enough, I mean, you're not up there to understand drug or, you know, physiology and stuff. It's not right. They are ready. If they are going into doing something, that means you'd prevent them from doing it at the start. So the maximum population which is affected, as we see, is about 35 years. But before 35, they were 34. They were also 25. So start educating the population before they start those kind of, going to those kind of addictive behavior or trying to look for extra pleasure out of getting those drugs or things. So education at a younger age is another policy change, which, as everyone suggested, that we should have more training and opportunities for students to understand these effects, ill effects of these kind of drugs.
We're glad to open it up to questions from the audience, so please come down. The microphones are on either side of the stage here. Hopefully some of you have questions or comments to share with our panel. I will note, I'm up here on my phone fact-checking about President Trump. He did, in fact, sign that bill.
Oh, good.
It's called the Support for Patients and Communities Act, and it boosts access to addiction treatment and other interventions. So if you're interested in learning more about that bill, it's called the Support for Patients and Communities Act, and it became law in late October.
Great. Good.
That's a good thing. Yes. No questions.
Maybe we should ask them questions.
Right.
Yeah, feel free.
So what do you think?
You should ask your survey questions.
Right.
You can do the
So
survey.
yes, how many of you actually did the survey? I don't know. Nobody's going to raise hand. Don't do that. I know some of you did. Because there was a good response, and I was very happy. Initially, I thought most students, I was actually told by people that students don't take survey very well. But I know, because for a fact right now, that people in first 2 hours of my survey, I had almost 400 responses. So that was like amazing. I was like, that's the interest at least the students have to take survey on that topic. So I'm sure some of you took it. So why did you, or what do you think is the need for such surveys? As students, what do you think what these kind of surveys are going to do? Anyone can answer. It's not like a class I'm going to point on people, right? Let's see.
Do you want to, you can tell us some maybe about your motivation for why you wanted to ask these questions of our student.
Yes, so yes, I'm a clinician by background and an epidemiologist too. So why I started the survey is there is no enough data right now to even support or to show that, or at least there is no valid data to say that New Jersey, or for example, this area, if you, I'm going with that. Statewide surveys that doesn't exist. You only have national pools, selective population from around the place. And people say that, you know what, there is a problem. That just comes up because you are looking at a nationalized data just collected by surveys. I wanted to have better valid data to say that actually students have some knowledge. People, actually out of the survey, I also was impressed by the fact that most students knew what these prescription drugs are addictive. That's not the case everywhere. You should be proud of yourself. At least students know that the fact that prescription painkillers are addictive. Even though there was a group who also said that prescription painkillers are safer. That is also a thought. It's a perception. Prescription painkillers are safer because it is prescribed. Because it is prescribed by a doctor or a physician, that's a misconception. Not always. That is the fact again. Because that's again come out of the same survey which said that prescription painkillers are addictive. On one hand, it also said that we believe in the prescription drugs better than other drugs because it's prescribed. That is also a misconception that it is not always right. There might be other things. When you talk or ask for any kind of prescriptions, you should have that awareness that this might have side effect. Ask your physician or your provider or any healthcare provider, whosoever is prescribing, what are the ill effects? What is it going to do other than masking my pain or doing whatever it is doing? What are the other effects? What are some of the side effects I could have? What is the long-term effect of any kind of drugs which you're prescribing? How is it going to affect me? As I said, there are few, out of the studies we said it's more Percocet and Vicodin being taken by students. Percocet is an addictive drug. It has opioid in it along with acetaminophen. It is a combination. But yes, it is addictive. Why should you take it? Is there an alternative? If you know about it, you're going to ask about it. Otherwise, don't just blindly believe in some prescription, always thinking that is the only way out. That is something which comes out of the survey that education is needed. Again, it stresses the fact that awareness is still lacking even in that population, the youth 18 to 25, as I said. The population still lacks in awareness about drug use and misuse, and which has to be handled in a better way. So the idea of taking this was to see where we stand, and from there, also the second phase of the survey goes to other colleges too, and also the plan is to develop training programs whereby these students go into community and they are going to train or they're going to talk about these kind of effects to high school students. So that's how the community awareness is going to happen. So the idea is to start to see as a pilot survey to see what our awareness is right now, and then to train the students and then move into community and also educate high schoolers. And all, not just by myself. Obviously, I'm not the best person to do that, to involve counselors or people who are collaborated with people who are actually good in that field and introduce those kind of training methodologies. So that was the motivation is why is it happening? As in, why do we have to wait for that hitting that crisis mode? Idea is to get primary prevention motivation. That is my motive, to get primary prevention more rigorous into community.
Awesome.
That's about it. Right.
Awesome. Yeah, that's great.
Yeah, thank you.
My students, when we talk about the history of medicine, and we talk about some of the archaic things that were done, 100 or more years ago, like bloodletting and leeches and things like that. And we think, oh my God, how could we actually do that? I think even George Washington, I believe, actually died of that technique of bloodletting because they thought when you're ill, you had evil, not spirits, but evil. I guess.
Yeah, it is. That is how the thought was.
Things inside of you, so you had to let the blood flow out. Can you imagine? Well, I wonder what are people going to say 100 years from now when they look back at the practice of medicine today? And when I say medicine, I mean everybody. When they look back and say, you prescribed what to people? Opioids? You did what for people who had back pain? You did surgery? You cut out this disc? This disc that is part of your anatomy? Why did you cut that out? So many people have these surgeries and don't get better. And again, I recommend the book. I did quote from his book, Norton Hadler. He's a rheumatologist, a book called Stabbed in the Back. And he takes medicine to task. He's a physician himself. He says that things we're doing right now or in many cases, more harmful than good. Prescription of certain medications like opioids, the overuse of surgery for problems like back pain. We've got to stop and think about what's going on out there. How much of this is being driven by the profit motive? How much is it because certain people are benefiting financially by the use of opioids, for example? So I'm really glad to hear the research you're involved in there. It's great. It's great. You know, we got to do more of that.
Yep,
Yeah.
we have to.
Yes.
That's what is needed for the community.
Well, I think in some ways this, please, come on. Go ahead. Yeah.
Okay. So my question, we know that those who become addicted to prescription painkillers may often become addicted to harder drugs such as heroin. So my question is related to things like the clean needle exchange programs, which is seen as like controversial for some people. So my question is, what can your field do to target that issue of addiction at the community level in a non-judgmental way for those who are already seeking safer alternatives to their habits?
Really great question.
Yeah.
Thank you.
Yes. Yes. Did you want to?
Yeah, you can start again. I will talk later.
What a great question. And I'm fully in support of clean needle exchange and anything we can do to help people who have addictions. Addiction is a disease. It's a disease, and it has to be treated as a disease. And I saw it firsthand. My nephew, he was a cage fighter. You know, they get in the cages and they pummel each other until one of them can't get up anymore. So he's involved in this cage fighting for years, about 10 years ago. And of course he got hurt. I mean, so often, every time he's in a fight, he'd have some injury. So he'd go to his physician, OxyContin, over and over again. So and after a while, when the OxyContin ran out and he couldn't get any more OxyContin, he found out, well, heroin's cheaper. And I can get it very easily if I just drive into Camden. So that's what he did. He started driving into Camden, shooting up, and he OD'd twice. Thank God for Narcan, but he OD'd twice. Now he's recovered as best he can. He's not the same person as he used to be. But we all almost lost him twice. My poor sister, you know, what she went through at the time, even 10 years ago, really didn't know what to do. What do we do? She kept talking to me, what do we do about him? I don't know. It's a horrible thing. So anything we can do to help, it's a disease that needs to be treated as a disease, not a social stigma, not, you know, this is a horrible person, and how could you let this happen to yourself? It's a disease, needs to be treated as a disease, so 100% in support, clean needle exchange, anything we can do to help people that have this disease.
So on the same topic again, as you suggested, because I said I'm going into community, talking to people, doing focus group with drug, this kind of drug court. I went twice just to see, what is their perception about how it happened or why it happened. Do you look at cancer or diabetes or heart disease like, it is a stigma? You don't. Why not then addiction? If you consider that as a disease, and people used to think that you have to hit that rock bottom to get treatment done, that perception has to change again. It is changing, but again, we have to bring to that point that you don't wait for stage 4 cancer to happen to get it treated. Same for addiction. If you look at the same, again, if you look at addiction as a disease, which involves multitudes of factors, but if you start treating at the initial part of it, it has better results. Again, needle exchange program, I'm a supporter of it because of addiction, there are other diseases which are happening because of dirty needles and injections happening. The hepatitis C, HIV, those are also increasing because of dirty needles. Infections, heart disease, there are so many things you can look at, and you will see that people who are using the same needle, you are taking the needle from somebody else, and there are certain areas right now which are known. I don't want to name those particular areas, but actually in the heart of that place, if you go, you see people pushing that needle on trees and taking that needle out and then injecting again. That is the situation where addiction is going, right? That is where addiction is right now. So you cannot look at it as a stigma. It is a disease, and it has to be treated like a disease, and that perception has to change. That social perception of it as a stigma has to also change. That's another thing which we as a society need to look at and start looking at it as a disease and treat them, not to push it away and ignore them, or it is an abuse, don't go near them, don't party, they are not the good people. That kind of change also has to happen. And yes, it is, I know there are different talks about it, about why it should not be there, because you're encouraging people to use needles for injection. That's another thought, but because if you're already addicted, you would need them to wean off through right method. And it helps, along with other measures. It is not just needle exchange program, you also need other interventions to help with addiction.
It's often the case, you can correct me if I'm wrong, that at these clean needle exchange sites, there's information about how to divert into a treatment program. Yes. So they're often used as a site, not just for the clean exchange, but information about these alternatives and how to seek treatment for your addiction.
It is there available. And 1 week, again, as I said, sometimes what happens is, again, the same thing. Mental health is not covered. Insurance doesn't cover your mental health very well right now. If you get treatment for a week, 2 weeks, you're thrown back into the same position. It is not helping that disease. You're stopping the treatment not even halfway through. You're actually causing something bad, worse to those patients than treating them for 2 weeks and leaving them, addicts, I'm talking about the addicts, you're treating them for 2 weeks, and then if they are left back, the chance they go back and do it is, that's what I said, the relapse, it is higher than before they started. So it is worse. So it's a long-term plan, and it has to be seriously taken for people who are already addicted. Yes, and again, pre-addiction, it's a different way of looking at it than prescribing alternatives. Yes, that is the plan.
All right, well, it is exactly 4 o'clock, which is the end time for our panel. So I want to give our panelists a round of applause. Thank you so much.